Well, welcome to this session about technology sponsored by Merrill. The title, Next Generation Complex PCI Toolkit and Novel Balloon-expandable Myval THV. My name is Andreas Baumer from London. I'm here with the spokesperson, Davidson Deepak, and we've got a panel of discussants, Abdul Rahman Al-Mulgahiri, Mohamed Al-Mukaini, Wael Al-Kashkari, and Ignacio Amat Santos. What we want to do in the next 90 minutes, we want to present some of the technology that comes out of Merrill, understand novel tools and techniques for the management of bifurcation lesions and long diffuse lesions, learn about Myval, the next generation valve technology, key features and benefits, talk a little bit about CorAlign technique and commissural alignment, and the sizing that we can get from the Myval THV. That said, I think we just get going, huh? Yeah. And I invite Davidson Deepak to talk about complex lesion management and the metal-free PCI. Now, throughout the session, there is the app. You can ask questions. You also can, at the end of the talks, come up and ask questions on the microphone. And at the end of the session, don't forget to rate the session with the star systems. The questions will come up here on the panel, and we will try to answer. Let's go.
Good morning to all of you. First of all, let me take this opportunity to thank Team Merrill for the opportunity given. Well, over the next 10 minutes, I shall share with you on two small topics. One regarding metal-less PCI, the next generation BRS, the thin strut BRS, 100 microns BRS, the cerebral image eluting BRS. And secondly, on the dedicated bifurcation system, the BioMime branch. I'll start with BioMime branch. Basically, it's got, this is how the BioMime branch stent would look like. You have at the end of the stent, the most distal portion, it's for the branch. You have a smaller looking area. Then you have the flexi connectors, and then more proximally, you have closed cell design so that you can have a proper scaffolding to the vessel wall. Well, regarding the design of this technique, it's basically a diligently designed tapering balloon system, wherein you proximally you have a much bigger balloon system, and distally it's a tapering system, and you also have a tough side branch portion of the stent. It's got closed cells so that you have better scaffolding of the side branch ostium. Then you have humongous flexi connector cells so that you can easily cross into the distal main vessels through these flexi connectors. And more proximally, you have a very sturdy closed cell main vessel anchoring segment also. Well, this is how the stent system would look like. Coming from most distal to the most proximal portion, you have 4 markers. Most distally, you have 1 marker here, then the second marker. The second marker from the distal most portion, it indicates the ostium of the side branch. Then you have 2 markers for the main vessel also. So one needs to be always careful with the second marker from the most distal portion. And then basically, it's a, you could see here that in the most proximal portion, it's got closed cell design. In between, you have large flexi connectors so that you have a lot of space between these connectors so that it makes you easy for you to get recross into the distal main vessel once the stent is deployed into the side branch. So this is how it's deployed. Once you prepare the lesion, the stent is positioned in such a way that the second marker is right at the ostium of the side branch. It doesn't protrude into the main vessel so that whatever sturdy stent struts are there, it's primarily for the side branch, and then it scaffolds the ostium of the side branch. Then here you have the flexi connectors through which you can recross into the main vessel. So this is how the stent is positioned. Then the stent is deployed. Once the stent is deployed, you could see that these huge spaces, the huge cells are actually lying over the ostium of the distal side branch through which you can easily recross into the side branch. Then you can deploy a stent in the side branch and then recross into the side branch, and then you could have a final kissing balloon dilatation. Primarily, it's something like a modification of a culotte technique. And this is how you, in the fluoroscopically, the stent system would look like. You could see that there are 4 markers. The second marker is more important. The second marker should be positioned into the side branch so that it doesn't protrude protrude into the main vessel. Well, this is the case history of a lady who presented with an acute coronary syndrome. She had an angioplasty to the circumflex. She also had an LAD-D1 bifurcation stenosis as seen in this particular images. We prepared the lesion, the diagonal as well as LAD was prepared, and that's the image how it looked like following preparation of the lesion. Then we did an imaging of the main vessel as well as a side branch. We made out that the vessel size of the proximal LAD was almost 3.5 plus. The daughter vessels were 2.5 and 2.75. Then we went ahead with the biomem branch stent implantation to the main vessel as well as to the diagonal. You could see the positioning of the stent in such a way that the second marker from the distal portion, it should remain inside the side branch. If it comes proximal into the main vessel, what could happen is the closed cell design would come over the ostium of the distal main vessel, so that it could make us difficult to recross into the distal main vessel. So that is how the stent is deployed. Once the stent is deployed, this is how it would look like on OCT. You could see here that in the distal portion, that's the diagonal portion, you have the closed cell design, and it's very sturdy. It scaffolds the ostium of the side branch very well. Then you have the flexi connectors here. You have the large cells over here through which you can recross into the side branch, that is into the main distal vessel. And then here you could see here that there was proximal malapposition. Normally you would size the stent in such a way that you have 3.5, 2.5, you have 4, 2.5, which means that the 4 millimeter diameter for the proximal vessel and then 2.5 millimeter for the side branch. So you could size it accordingly, and you could see here that the wire has gone into the side branch. The wire in the diagonal branch is clearly seen. The wire going into the distal left antidescending artery is very clearly seen. Then you could go ahead with dilatation, then the stent implantation inside the main vessel. Following that, pot recross into the side branch, kissing balloon dilatation, repot, and that would be the final result like. And OCT wise, you could achieve a good flow. Those are the OCT images, and that's a 3D image showing us the stent positioning right at the ostium of the circumflex. That's from the ostium of the LAD. The circumflex ostium is clearly seen, and also distally we could see the LAD-D1 bifurcation also in the OCT image. That's the LAD-D1 bifurcation. Well, this is another example of a patient who presented with effort angina, 50-year-old gentleman, LAD-D1 bifurcation stenosis. We prepared the lesion, and following that we positioned the branch. In the second image, you could see that the biomem branch is positioned in such a way that the second marker from the distal portion is well inside the side branch. But however, what happened was during the stent deployment, somehow the stent got positioned in such a way that the second marker, it was more into the main vessel, which means that the closed cells are going to be over the ostium of the distal main vessel. However, you could see that the flow inside the vessel is good, and LAD as well as diagonal is good. It will make us difficult to recross into the distal main vessel. Now we did a pot, and subsequently we recrossed into the main vessel, and once we recrossed into the main vessel, we did an OCT pullback from the side branch just to see how the struts look like. You could see here that this is the side branch, that is distal main vessel ostium. You could see that the closed cells are actually over this particular area, over the ostium, which means that the positioning of the stent was not properly done, and one should be meticulous in positioning the stent in such a way that the distal marker of the second distal marker should be well into the side branch, so that you do not have these closed struts coming over the ostium of the distal main vessel. Again, in this particular rendered view, you could see clearly that the closed cells are actually lying over the ostium of the distal main vessel, which could make us difficult to get into that vessel, and even pushing the balloon also could be difficult in these situations. Then finally we were able to dilate it, we were able to stent it, then recross into the side branch, kissing balloon dilatation was done, final pot was done, and then we were able to achieve good results. So this is just to highlight the fact that this particular stent system, the stent system with a tapering balloon and a proximal huge cells that can make us easy to recross into the distal main vessel, could prevent us from closure of the side branch. And there are many advantages for this biomem branch. It simplifies the procedure. It's primarily a modification of the Culotte technique. It simplifies the procedure and thereby shortens the procedure time. It could reduce the risk of contrast nephropathy because the procedure is going to be much more simpler. It could improve the procedure success rate, allows permanent side branch access because the side branch ostium is covered only by very few struts, and final optimal stent expansion and side branch ostial coverage could be achieved. Well, coming to the new generation BRS, the MIRAS by Merrill. Basically, why do we want to have a second generation BRS? We know from the ABSORB 4, the four-year outcomes of the ABSORB trial that as time goes by, you tend to have more and more of events. So how can you reduce the events with the newer generation of bioresorbable scaffold? Primarily try to improve the device. That is, you could have thinner struts. ABSORB had 150 micron struts. Here we have with MIRAS, it's 100 micron struts, and you have mechanical properties of the device is much better compared to ABSORB. And then the technique of implantation also, one should be meticulous. Probably one needs to pre-dilate, do imaging, post-dilatation. All those things should be given a lot of importance, and a prolonged DAPT could fetch you better outcomes in the long term. Now, what way is MIRAS different from ABSORB? Most important thing, it's a sirolimus eluting system and 100 microns, and you could see that it's a hybrid cell design. In the most proximal portion, you could see that it's a closed cell, and in the mid portion, it's an open cell. So in the most proximal as well as distal portion, you have the closed cell, which provides you a good radial strength, and in the mid portion, you have open cells so that you could have a better access to the side branches. Well, you also have a better radio-opaque, triaxial radio-opaque markers so that you can very clearly see the positioning of the stent compared to the first generation BRS, wherein it was difficult for us to identify where the markers are. Well, again, this is how it would look like compared to ABSORB. You could see that it's 100 microns compared to 150 microns. The initial first generation used to be a more boxy one, and this is how the radio-opaque markers would look like compared to the ABSORB. You could see that there are 3 radio-opaque markers. The triaxial radio-opaque markers are very clearly seen so that you wouldn't miss it actually also. Now, this is an example of a case, a patient who presented with an anti-wall myocardial infarction who was thrombolized and then taken up for an angiogram. He had an OM lesion which was stented with a biomime stent, and then we looked at the proximal left descending artery, which was a culprit anti-wall myocardial infarction. You could see here that there is a small ectatic segment beyond the tight stenosis in the left descending artery. We did an OCT evaluation. The proximal vessel was 4.2 millimeter. The distal vessel was 3.9 millimeter, and the ectatic segment was almost 6 millimeters. So we wanted to use a MIRAS in this particular situation so that even if it overhangs into the ectatic segment, probably over a period of time, it will disappear over a period of time. So we decided to use a 3.5 millimeter MIRAS and post-dilate with a 4 mm balloon. So that was how it was done. We could see that the MIRAS is being pushed into the coronary artery. You can see the markers very clearly. The stent was positioned in such a way that the marker is right at the ostium. Proximal to the markers, you have just 1.2 millimeter of the scaffold protruding into the main vessel. Then it is deployed at 14 atmospheres. It was post-dilated, and those are the post-dilatation. And then you could see that the repeat OCT evaluation shows us that the strut is around 110 microns. And you could also see that despite doing post-dilatation with a 4 millimeter balloon, there was some proximal malapposition near the ostium, which was further dilated with 4.5 millimeter balloon in a 3.5 scaffold. And finally, we were able to achieve good results. Those are the final bifurcation image showing us that it is well opposed, and angiographically the results were looking reasonably good. So regarding take-home message, dear friends, imaging while using a BRS, it's always imperative that we use imaging so that we tend to see the vessel architecture. The vessel can be well prepared with cutting balloon or scoring balloon. If it's a fibrotic lesion, we could size the vessel very clearly. Proper pre-dilatation is a must. Tracking the scaffold is not difficult in many of the lesions. Positioning, one should make sure that while positioning it at the ostium, one should keep in mind that proximal to the radio-opaque marker 1.2 millimeter, the scaffold protrudes into the main vessel. Do not undersize, because once you undersize, what could happen is it's little bit boxy, 100 microns, so that the next balloon might hit at the side of it, and you might find it difficult to push it into the vessel. High pressure post-dilatation is always preferable. Post-dilatation probably should be 0.75 millimeter more than the size of the scaffold that we use. In a 3.5 scaffold, you could go up to 4.25. We have gone up to 4.5 without no much of damage to the scaffold. And post-procedure imaging is always preferable, since we need to have a perfect result. We shouldn't have a mishap similar to what we had with the first generation stent. Thank you so much.
Excellent. So that was a 2-in-1, new bifurcation stent and new absorbable technology. Let's ask for questions. We're having a little problem with the online systems. If you have a question, please stand up and come up to the microphone.
May I ask a question?
Yes.
What kind of bifurcation this stent will be suitable? It fits in all bifurcations?
That was my question.
And it was my question.
Basically, you have a flexi connector system. So even when you have a short angle or a large angle, you could use it any sort of angle. So primarily for any sort of bifurcation, this could be used. But then the challenge would be the length of the system in the proximal segment. When you have a very short LED D1 bifurcation, the length of the stent that protrudes proximally shouldn't overshoot into the left main. So that is one important thing that needs to be given importance. But then looking at the angle, any angle, it could be chosen for a bifurcation strategy.
Have you used it in a distal left main bifurcation?
We have done a couple of cases in distal left main, but then the challenge here is the proximal vessel, the proximal left main should be long enough to accommodate the proximal length of the stent. That is the only challenge that you would face. And in a non-dominant circumflex system, you could easily use it. You can use this 2.5 or 2.75 side branch system and post-dilate it into a 3 or 3.25.
Yeah, maybe this is appropriate for non-left main bifurcations, but for the left main probably is a different. What I noticed from the stent design and the positioning of the side, so it does not fit for the maybe for the bifurcations non-left main related. So it's circumflex OM LED diagonal, maybe this one.
Is this system now widely available in the region, or is that still, test pilot sites or within a pilot series?
I had recently sample from the company, but I never use it. But I agree with the Abdurrahman and the rest of it. I think the best is when you're gonna use it in mid to distal LED or CERC or RCA, where you that's acute angle, you anticipate a problem. I think it is, for me, from the technology shown by Davidson, is the best to be used in that area.
Okay. One or two questions on the absorbable scaffold. Just a show of hands. If the absorbable technology would come back, who in the audience would use it right now on patients with simple lesions? Good, because I think there's a slow comeback coming. What do you think, Ignacio?
Well, I think
what would you be what do you need from a technology to say, yes, I'm going to put that into the patients?
I think there is a clear trend to try to restore the vessels instead of implanting a permanent scaffold. This is why DCBs, the drug-coated balloons, are extending very quickly, and all the resorbable technologies are coming back also very quickly. We learned a lesson from Absorb. We need to predilate well, to size correctly, to post-dilate well, to do imaging, and I think now we have more evidence with October and other trials, so I think that will be key. Better technology and better procedures. I think there is a role. But if you have a distal LED that is for DCB or resorbable scaffold, what would you choose? Which would be your criteria for that?
Given a chance, if it's a lesion that recoils, probably I would go for a scaffold. If it doesn't recoil and with no much of dissection, probably for a DCB.
Okay. I have a comment on this part, because similar to the renal denervation, once the technology destroyed, reviving it again, it takes maybe longer if it is going to come back, because the scaffolds failed clearly because of the stent thrombosis, the recoils. So the operators became shy from going back to it, and unless they have a very strong evidence, it's coming back strongly with low profile.
Yeah,
yes,
thank
the first generation scaffold, it failed in smaller vessels. So probably till we achieve huge amount of data with this scaffold, probably we should be using in larger vessels rather than using in smaller vessels.
Prepare the lesion. The most important is to aggressively prepare the lesion before you put the bioresorb.
I think it's true. The comment was there that we have learned a lot of lessons in the first generation, and here is a new generation that is worthwhile testing. Thank you very much. We're moving on. We're going now to tapered vessels and tapered stenting solutions. Sami Lawand. Welcome. That's an interesting one, because we never really think about the vessel length, that the diameters are so different at the beginning and at the end if you really treat long lesions. So what do we do?
I'll try to help. Can I have my presentation, please?
And we're up and running with the questions, so if you have questions, you can type them in the app.
Okay, assalamu alaikum. No conflicts of interest. Basically, I'd like to just go over the issue of what are the anatomical situations that we face when we are dealing with our coronary artery disease, particularly with the current era of diabetes and diffuse lung lesions. Of course, as you know, naturally vessels do taper over their length, and with that, we face another channel. The prevalence is high. Long diffuse lesions seen especially in diabetics are subject to high rate of restenosis. We may have to end up with multiple stenting, with overlapping segments, and these overlapping segments can cause issues like delayed healing, whatever thrombosis, etc. And there is a pattern of change in the size of the vessel as it goes. Now, we are compelled most of the time to use at least two, sometimes more than two, for more than 48 millimeter long lesions. We often taper proximally to distally, and then stents are deployed in an overlapping manner, and we know what we have had seen before with overlapping issues. This is a typical example of a patient with a diffuse disease and having to predilate and then treat, etc. So I will basically just go over the issue of what problems do we have when we face these vessels. We put a segment in the middle where overlapping double-layer stents are there with their possibility of jailing a nearby important side branch. All of these double layers, etc., the jailing, the likelihood of having double dose of the drug, etc. This is a schematic representation of how it looks from a metal point of view, where you can see that the amount of metal in the middle is quite high. Then it tapers off towards each of the sides. And basically, binary restenosis is much higher at this level. Also, a distribution that allows problems related like thrombosis. Potential site for restenosis do occur, there's no doubt about it, and then we have to really be careful with what we do. In this case also, sorry, I'm pushing the wrong button. Typically, we also have to account for the change of the vessel size, and that amounts to a change in the size of the balloon and length of the balloon, etc. And also, in fact, over dilating sometimes distally compared to proximally, or under dilating when we put a different size stents in different areas. All of these potentially cause trouble to our estimation. So I'll go through some of my cases that I've done before. This is a gentleman who came with an acute inferior STEMI, trop I up to 48,000, etc. And then he was rushed to the cath lab to do what's going on. So this is his right at the onset, and then we managed to recross, and we discovered this particular lesion and distal lesion in the right. Distal segment, you can see it's a hard lesion to open up, and basically got better. Only to discover that the LAD has multiple lesions from the proximal to the mid to the distal, and we had to predilate, and end up with a 60 millimeter 3.5 3 millimeter 60 diameter with a 60 millimeter length. The reason I showed that, because I ended up thinking that I may actually need up to 3 stents in order to cover the whole segment, and with that, multiple areas of overlapping segments. So I reduced the number, I tapered the size accordingly, because this is a tapered stent, and avoiding overlapping. And with that, I got this result. There's still a segment not covered despite the length, so I ended up dilating more distal to the stent, and with that, then post-dilated everything and put a drug-eluting balloon, and this is the final result. The second case is a 74-year-old diabetic hypertensive thrombocytopenic patient whose usual platelet count is around 75 to 80, admitted with acute coronary syndrome. And the question is, again, his enzymes were quite high, and the question is, what would be the strategy? This was what I found: normal right coronary artery, and this is diffuse LAD with more distal disease. And basically, it is a strategy that I have to think of, and then end up with what should I do. One stent should be enough if I can, but if there is a more distal lesion, I can use a drug-eluting balloon, and this was my target. I started pre-dilating. The issue of the matter is proper pre-dilatation and preparation, because this is a long stent, and it has to be very well prepared, especially if there is calcium. Also, before that, I decided to fix the diagonal, which I thought is adequate size enough, only to discover the diagonal turned out to be very highly fibrotic and calcified. Even the balloon did not open appropriately. After repeated efforts, I managed to do that, and there was a residual dissection, so I ended up putting a stent, sparing the real ostium, just because I expected that the size of the LAD will cover the gap. And then after post-dilatation, I went to the LAD itself and pre-dilated adequately, and then here I come with my 60 millimeter 3.53 diameter stent deployed properly after adjusting to the ostium. And then I looked carefully into the deployment, starting distally, lower pressure, then higher pressure, then larger balloon, and then eventually and finally getting the result. Again, and that's a careful final result. And then I did a DCB to the distal end. Case 3 is a patient who, again, with acute inferior STEMI, and there was a more challenge to this case. Again, I thought of covering a long stent segment. The occlusion is more distal, and there is calcium everywhere. And you can see the shape of the balloons are deformed, and I needed to do a lot of pre-dilatation. This is the result. Not much of a good result. Again, some improvement, further pre-dilatations. It took a lot of effort only to end up with a 50 millimeter, because I did not have a 60 millimeter stent at that time. And again, tapering distal edge, and I started fixing inside the stent by combining both stent boost and higher pressures as I go more proximally, and eventually correcting for all possibilities, only to discover a dissection, not really a dissection, residual lesion distally, so I thought it's better to add another stent, and that was done with adequate result. Only to discover there is a chunk of calcium sitting there that I had to dilate, and I ended up dilating with a very satisfactory result. This is his left circumflex. It had a severe middle lesion. LAD was satisfactory, and again discovered very heavily calcified segments. Balloons were not able to open up. Stent was advanced satisfactorily, but then I had to fight with the stent under deployment because of calcium, and by those dilatations, etc. So eventually, there's a side branch that had a lesion, so I ended up putting a drug-eluting balloon at the distal edge, and with that, one stent here, one stent there, and that is it. So sirolimus-eluting stents with tapered tapered ends and long coverage is here to stay. They are likelihood that we should use them as an integral part of our armamentarium for diffuse lesions that are increasingly common. Long diffuse lesions can be better treated with single long stents to minimize the risk of fracture, binary stenosis associated adverse events, and I may add here thrombosis. I've had several thrombotic lesions occurring at the bifurcation. It's convenient and it can be cost reducing. Anatomically designed tapered stents may provide better stent conformability and without altering the vessel. This is how they look. They have closed cells at both ends. They taper in size and open cells in the middle with very well conforming to the vessel. Thank you.
We've got time for one question, if there are any. Will we see a case series? Will we see a registry data or even randomized data?
Yes, I've been doing this since 2017. I presented my first case at the TCT at that time. And since then, I've done more than about 150 to almost 200 cases.
Okay, large experience. Thank you very much.
You're welcome.
Okay, we change the topic completely, and it's a pleasure to have Ignacio Amat Santos here to talk about the Myval, and I think the first talk will be just really an overview about the technology and the experience so far. Myval THV design philosophy.
So before he starts his presentation, can I just make a comment on this particular presentation, because this previous one.
Okay.
Yeah, this particular the tapering stent system, in India it's called as the biomorph system. It's available for the past 8 years, and we had the opportunity to present the initial 150 cases at EuroPCR in 2018. And the outcomes are very similar to the other stent system. In India, we prefer using all these 60 millimeter stents. Primarily, we could reduce the number of stents for the patient so that the cost could be significantly reduced. In the past, it used to be very tough managing this, tracking these stents with buddy wires, things like that. But with the advent of this guide extension catheter, it's not at all an issue at this point of time.
Okay. Well, thanks for that additional comment. Thanks. That rounds up the presentation. And now we go on to the Myval.
So thank you very much for having me. I will change to a larger stent, the stent of a Tapered device, the Myval device, and I will present some of the evidence that we have and the evidence that is coming pretty soon within the next year. This is the Myval device. For almost 2 decades, we only have one balloon-expandable Tapered device. So you are seeing the first device that was designed to compete with that and to offer our patients more alternatives worldwide. You can see that the design presents hexagonal cells on the top, and then these smaller cells. And then there is this skirt that is not is presenting these valleys that is important for some of the indications. Then they have intermediate and extra large sizes, and these are differential aspects of this device. When we are implanting, it's important to determine this kind of radiopaque bands. You can see this second band is our marker for positioning. So when we are trying to land in the aortic annulus, we can use this band. If we want to go higher, we can position here. If we want to go lower, because coronary arteries, for example, are very low, we can position here. And this is the recommended implant position. It's very important that this valve remains in a quite stable position. There is not much foreshortening. When we use self-expandable devices, there is quite foreshortening when we deploy the valve, but this kind of design can allow quite precise positioning. Of course, if we use the flex, we should remove the flex of the delivery system when we are implanting to reduce even more this kind of foreshortening. But you can see how long a self-expandable valve is before deployment and the foreshortening it presents after that. So the number of studies that we have regarding the Myval technology is growing very, very quickly. Now we have more than 80 publications. We have more than 12,000 implants worldwide. And the most important trial, the landmark trial, is going to present results pretty soon. The recruitment for this trial was completed last week. This means that in January next year, we will have 30-day results comparing the Myval series with the Sapien series and the Evolute series, which is going to be also one of the first comparison between all these 3 platforms. There are not so many head-to-head comparisons of different TAVR platforms. We have these studies, the CHOICE, the Portico, the Reprise, the SCOPE trials that had a great impact, and now we have the landmark trial comparing the platforms. And I think the endpoints were chosen very carefully to be really relevant from the clinical perspective. So the main endpoints were the mortality, the stroke, disabling stroke. We also have the bleedings and the vascular complications, acute kidney injury, and what we really look for new platforms, moderate and severe paravalvular regurgitation, and the permanent pacemaker rate implantation. So this is the target of this trial. I cannot present results yet because, as I mentioned, this was just finishing the recruitment last week, but there are some video densitometry analysis that suggest very low rate of moderate or more regurgitation with all the platforms, which is a very good information. We are pending the core lab analysis, and the preliminary information also suggests a quite low pacemaker rate as a mean in the whole population. So these new platforms, new technologies with our devices are very interesting. The nested cohort with the XL sizes, this means the 30.5 and 32 millimeter valves, is still ongoing, so there will be more cases to recruit, and this is a very interesting cohort for patients with large annuli and bicuspid patients and some scenarios that we are all facing. And before we have this kind of information, we performed a retrospective analysis that is called the Matchball study that was published in Heart last year. Of course, these retrospective comparisons have some selection bias in our patients, so the primary endpoint was mainly the hemodynamics, and for that there was an adjustment by the ejection fraction, baseline mean gradient, but also the annular characteristics, including calcification, diameters, area, and eccentricity. We included all patients with three-leaflet valves, and as I said, these were the primary endpoints, all of them hemodynamic, but we also checked the clinical outcomes, comparing the Myval and the SAPIEN 3 series. The match cohorts were more than 100 patients each, and regarding the results, there was a lower pacemaker rate in the Myval cohort. This required further analysis, of course, and there was a trend to better clinical efficacy and early safety information. Importantly, the mean aortic gradient was significantly lower with the Myval compared to the SAPIEN 3, probably based on the availability of intermediate-sized devices that allow a more appropriate sizing of the valves. And regarding global aortic regurgitation, there were no significant differences between what has been the best valve in this regard until now, the SAPIEN 3, and the Myval. We can see that there were no cases of severe regurgitation with the Myval, only one with the SAPIEN, and most of the rest patients presented mild or known degree of regurgitation. I mentioned the lower rate of pacemaker. We did a larger study with more than 1,000 patients with all the devices that we were using and analyzed centrally all the electrocardiographies. We could see that Myval pacemaker rate in our core was 7.4%, which was significantly lower than Evolut, Portico, and Allegra, and comparable to Accurate, 9.1, and SAPIEN 3, 13.4. But also the QRS duration at discharge was significantly prolonged with all the devices, but especially less prolonged with the Myval and the Accurate Neo devices. We also performed a registry in low-risk patients that was published in CCI last year, included 100 patients, and again we confirmed the safety with no cases of valve embolization, coronary obstruction, alveolar rupture, etc., etc. 40% of the patients require intermediate sizes, which is the only device that can have this kind of sizes. And again, we found a mean gradient that was below 10 millimeters of mercury and a global regurgitation with no cases of severe regurgitation, 4% of moderate, and the rest of the cases mild or non-regurgitation. The landmark trial, as I mentioned, is very important, but one of the exclusion criteria is bicuspid aortic stenosis. Of course, as in partner trials, there will be some bicuspid cases because there is always some crossover with the patients, but we performed again this Triton study, which was retrospective to understand how are behaving the current platforms in bicuspid aortic stenosis. We compare more than almost 400 patients and performed a 3-match analysis, again, mainly focused in the hemodynamics, but also adjusting by clinical variables, leading to 3 groups of 80 patients with SAPIEN 3 Ultra, Myval, and Evolut Pro Plus. And here what we could find is that the mean gradient with Myval was 9.7, with Evolut 8.7, and with SAPIEN 3 13.1, which is something that we already knew, but there were no significant differences between the Myval and the Evolut, only both of them with the SAPIEN 3. And there were no differences between SAPIEN 3 and Myval in terms of residual regurgitation, but it was significantly higher with Evolut Pro Plus, with only 2 cases of severe regurgitation. You can see that these anatomies are quite challenging in our patients, in fact, and often we have strange positions, we have to choose very carefully the sizing. So I think this information is very relevant from the clinical perspective. And I want to finish just mentioning the COMPARE TAVI randomized clinical trial that is recruiting patients in Denmark. It's still collecting patients, but there was a sub-study that I think is very important. This study, apart from the randomization of the patients to the 2 balloon-expandable devices, they perform a sub-study centered in cardiac magnetic resonance to analyze the residual regurgitation following TAVI, comparing these 2 devices. They used the 5-class gradient, but also the BAC3 classification for this comparison. There were also some proportion of patients with bicuspid aortic valve, and we can see that there were no significant differences in the degree of aortic regurgitation when we compare with the 5-class gradient or the BAC3, the Myval or the Myval octacore, and the SAPIEN 3 or SAPIEN 3 Ultra. When we calculated the fraction of forward flow, we could see that the median for SAPIEN 3 was 5% and for Myval 6%. So I think all this information is suggesting that probably in the next few weeks we will start to have some preliminary data demonstrating what the retrospective analysis suggests, and it's a very good hemodynamic behavior of the Myval device, and now we need to see the prospective clinical outcomes that might represent a breakthrough in our field. Thank you very much.
Thank you very much for launching us into the Myval section of this session today. I would suggest we have the discussion at the end, because it will all go about the same valve in different positions. Now we start with the pulmonary valve intervention. Afterwards we'll have large annuli, and then intervention for pure aortic regurgitation, and at the end we'll have a kaleidoscope of cases and how to deal with the valve in clinical practice. So the next talk is by Ata Firouzi, and it's about the pulmonary valve interventions.
Yes. Mr. Chairman, ladies and gentlemen, I'm happy that I'm here, and I want to share our experiences with Myval, and I want to find my presentation. I don't know how. Can someone help me? Yeah, it's totally different. My PhD. No. No. Oh, yes. Yes, thank you. Thank you so much. I don't have any conflict of interest in this presentation, and I'm working in a tertiary center in Tehran, and we are a busy center, and we face with adult congenital patients in our center. I want to say that unfortunately we don't have dedicated pulmonary valve till now for managing all anatomy in pulmonaries, and I want to insist that this kind of patients is not uncommon. As you know, tetralogy fallout is the most common cyanotic congenital heart disease, and usually all of them needs some pulmonary involvement during their lives, and other congenital abnormalities like conotruncal or post-RAS operations needs other intervention during their life, because we know that surgical improvements make their life expectancy higher than previous that we had. And in recent years, till recent years, the only option that we had was surgical intervention, but nowadays percutaneous intervention makes windows for them with lower risk and also lower complexity. But we know that when we do something for this kind of patients, we can have acute or late complication that we should know much about them, especially in pulmonary situation that is new. I categorize this intervention just as a practical view to valve in biologic processes and valve in native or homographs, and I want to separate them in my presentation. As you know, until recent years, the only option that we had for valve in valve was SAPIEN, and it was like aorta just deployment of the valve. We had problem in this kind of patients, because you know that in this case that you can see it was the smaller magna valves. It was 19, and the only option that we had for this patient was 20 SAPIEN. I don't sure that it's make effective area for this kind of patients in future. But luckily with Myval we have different sizes with 1.5 differences, and it make us better choosing the bigger valves with safety for being not worry about the malcoaptation when we overexpand them. It's important we know that the biggest valve has a better make a better cardiac performance, especially in high body surface areas patients. And we know that the nature of the valves, and we know that most of them are crackable, or we can remodel some of them, but as you see, just a small number of these valves we can't do something like fracturing or remodeling in them. And I want to say that in most of biologic valves that we have in our patients, we can go to bigger valves with maybe be a better cardiac performance in future. When you review the articles or something that our mentors said about the assessing the fracturability of the valves, is just in aortic position. But our surgeon said that pulmonary annulus is totally different from aorta, and maybe some of that criteria we can see in fracturing the valves in aortic position maybe is different from pulmonary. In our experience, the most important maybe thing that said that you are you can make fracture in the valve is resolving the vase with a sizable balloon, and also rapid decreasing in pressure in inflator. And to be honest, in more than 20 cases that we did, we couldn't see any fracture in rings in fluoroscopy or something like sensing cracking or other thing that or shattering that when you review the data, the articles you can see. But in pulmonary maybe it's different from aorta. In these cases, you can see it was the Magna 19 and inner ID. Magna 19 is something about 18 or 19 millimeters, and we chose the gold atlas balloon 20, and we with this pattern of assessing fracturing, we went to use the Myval 21.5 with 1 cc extra, and luckily we check with echo the coaptation and also the hemodynamic of the valves. It was very good, and it's make us that we can use the bigger valve with extra volume without deteriorating the coaptation or leaflet destroying during overinflation. And in these other cases, I want to show you that this resolving the waist of the balloon is something like this, and when you check the inflator in that situation, you can see the drop at the pressure, and it can show us that you overcome the annulus tightness in the previous valve, and we use the my valve in this patient because from jugular, because this patient had interrupted IVC, and then you can see that the sheaths and also the flexibility of the valves is very good for sending from different access. And then at the other hand, when you want to tackle the native valves or homograph, it's better to assess the coronary perfusion before doing stenting in RVOT, because we know that RVOT is very flexible, and in our expansion, we know that in some cases it can make coronary entrapment or pressure on coronary and can make dramatic results. And we in native pulmonary, we always do this kind of testing before going to implanting the stent or valves. In native valves or in homograph, there is two scores. One said that we can do the procedure in the same sessions, stenting and deploying the valves, and someone said it's better to postpone the valves after a while to do endothelialization of the stents in RVOT. To be honest, our strategy is this: if you do easily stenting in RVOT with a good radial force stentins, and you're sure about the resolving of the obstruction, and you're not worried about sending the valves at the same session, we can do it in same session. But when you have a complex anatomy, sending the stents is hard, and delivery is not easy, it's better to postpone the procedures to at least 3 months for endothelialization of the stent, because when you wanna insist to sending the valve at the same session, it can make crashing or valve loss in the balloon, and it's better to postpone it. I prepared 2 cases with different anatomies. This is the patients that you can see that anatomy is not so easy. Sending the stent was not easy, and we stented the grafts with Optimus stent. This Optimus stent is covered stent, but the coverage part is walled off by 2 layers of metals, and the stability of the graft is maybe better than some kind of other stent graft like CP, but this stent is nitinol, and radial force is not as high as CP, and in this patient we postpone sending the valves, and in first attempt, we did stenting with Optimus and with CP covered at the Optimus for increasing the radial force. And you can see in the last picture, we send the valve with Myval 3 months later, and you can appreciate this looping in delivery showed that the balloon has enough quality for sending the valve to complex anatomy, and we did it without any problem. And you can see that the result was acceptable. And in follow-up, we saw that in 3 months later, the gradients and also valve functions was good, without any shrinkage in a stents and also in valve. In these cases, you can see that the homograft is heavily calcified, but the accessibility is not so complex as the previous one. We did this procedure at the same session. We deployed 2 CP-covered stents in this tight area for resolving the gradients in the homograft. And after that, we deployed the Myval in these 2 stenting stents. And you can appreciate in last picture that the result is good, and the valve opened circularly without any pinching or deformity in the stents. In this case, we postponed doing the valve in the stents, and but to be honest, after doing the stenting in first attempt, that was something like the next, but after 3 months, we saw that some shrinkage in the stent. I don't know that it could happen in patients that we do pulmonary valve in future in some patients, but in this case, we implant another stents for increasing radial force, and after that, we implant the valves, but in 6 months follow-up in these patients, the results was good, and I did fluoroscopy in this patient, and I saw that the stents didn't have any fracture, maybe any squeezing, maybe the metal wall of the valves increase the support or increase the radial force of the stents that we implanted in it. And in this picture, I want to say that we worry about the, I think, because you know that Myval is implanted on a balloon, and we worry about the stability of the Myval in pulmonary position, but in this case, you can appreciate that in sequential inflation of the stent of the valve in the previous pulmonary valves, we could pull and push the valves for better deployment, and it's have a good stability in doing valve in complex situation, and in our cases we didn't have any problem with this delivery system that Myval had. And I want to say that when you tackle the pulmonary issue, you should be ready for nightmare situation like pulmonary ruptures, and in this patient that we had tight stenosis with calcification at the annulus, we send the sheaths before we park the sheaths in IVC. This is the dry seal sheaths before doing balloon valvoplasty at the pulmonary. And when we saw that we have a rupture, we send the sheaths fast to the RVOT, and we could manage these patients with pulmonary venous P valve in these cases, and we saved him. Luckily, at that time, we had that valve in our center. I want to say that we have many patients with pulmonary valve disease. They have always many experiences of several surgeries. They are young and with high life expectancy. Maybe we should have dedicated valves for pulmonary position, but in our experiences show that Myval could be choices for these kind of patients, and I'm ready for your experiences and your comments in these fields. And I will be happy to share our data with you if you work in pulmonary valve.
Thank you very much. Thank you very much. We move swiftly on, I think, and take the questions at the end if there is still time. But that was a very, very interesting insight in a field that most of us never really tackle. But thank you very much. And it's a great pleasure to have Abdulrahman Al-Mughayiri talking about the management of large annuli.
Good morning. I will not spend time on the valve itself. I will go to the science. So it's the so far what we have in the technology is the limitations. So and the technology did not stop. So always is advancing to help us manage our patients and to overcome the challenges we face. The currently available or commonly used for the TAFR are the two platforms, balloon-expandable, self-expandable, and they have their own limitations. While the balloon-expandable, they have the one started first is the Edwards valve with the areas nominated by the manufacturer. The maximum area is 683. And while the self-expandable from Medtronic and Abbott and the Boston and others, they have the limitations also with the maximum diameter they can reach is 30 with the perimeter of 94.2. And the extra large annuli defined as any diameter beyond 30 millimeter or area beyond 683 beyond the available limits or the perimeter as large as they stated in the reference. With the some recommendations to add 2 cc to have the oversizing by certain percentage, so the limitation was there. And as we see, the reference for all the devices available is this one. The Abbott, they have the size 35, but still lands in the Medtronic range, which is the 30 millimeter for the diameter, annulus diameter. The Boston valve is lying behind, also is in this one. So why we need the appropriate size for this large annuli or to fit the annulus? Because from the literature, the studies and the registries show that the undersizing is associated with BFL. BFL is documented to have the outcome is not satisfactory with the mortality, morbidity, hospital admissions because of the heart failure, because of the II, with variable management measures, either plugs or to seal it, to oversize with the available for the balloon expandable to upsize it up to 4 millimeters for the recommended by the manufacturer, or maybe the anecdotals to go up to 11 cc extra, and in spite of that there are some limitations as well. And for the sizing, any oversizing less than 12% is associated with BFL, and the outcome was not that good. So the appropriate oversizing is a 12% and above from the available literature. And we always lean towards this recommendation. And as we see, the presence of paravalvular leak, in spite of the oversizing, is still significant and continued up to 1 year from the publications available. And also if you oversize too much beyond the recommendation, so you face the valve malfunction or the intrinsic regurgitations with its own clinical consequences. And this is the comparison between the extra large and the controls cohort to compare with this one. With the paravalvular leak is significantly higher with the patients with extra large annulus. And for the assessment of the performance of the balloon-expandable by Merrill versus the largest or the self-expandable valve, it's almost comparable, except in a lower rate of pacemaker and lower rate of BVL if you compare it with the self-expandable valve. But the rest of the parameters, especially the stroke, is the same. In comparison for the sizing with the competitor balloon-expandable, also there is a favorable for the larger sizes. The rest of the sizes, the ranges are comparable. So there is a chance to have a benefit of this larger size by the Myval. And they have this range of even the intermediate, they tried to cover it in spite of some our efforts to either to increase extra CC to overcome this with the Sapien, or under using the larger size with reducing by 1 or 2 cc, but this came with the bad outcome. If you reduce the below the nominal, the outcome is bad because of the leaflet did not have enough movement, or the risk of thrombosis, risk of valve malfunction is very common. That's why going the nominal is the best approach to manage the patients to have the best outcome. And always the small annulus, large annulus is challenging. And it's the extra large annulus valve for the device. It's been documented and tested even in the pure aortic regurgitation, and with a favorable outcome. Survival is good. And we'll come to an example for this. Is an 87-year-old patient with severe aortic stenosis. He was admitted with heart failure, and he had moderate carotid stenosis, dyslipidemia, and the other comorbidities. Labs within normal. Echo showed normal ejection fraction. Severe calcific aortic stenosis is a bicuspid valve. And the gradient is as seen in the echo, and the coronary angiogram showed normal coronary adhesion sinus rhythm. This is the CT assessment. Is a type 1 bicuspid aortic valve, heavily calcified. The score more than 2,500. So, and this is his annulus perimeter is 100 plus. The area is 787, and one of the reports showed the area, because usually we compare 3 reports to compare. So one of the reports is 820. And the coronaries are favorable, the sinuses are favorable, sinotubular junction, the rest of the parameters are okay, peripheral is okay. This is a representative, it's not for this patient because the images quality was not good. Just this is to show the circle method, how to assess and plan the positioning to optimize your new valve in position. The circle method is helpful, and there are consensus to guide the operators to this one based on the registries and the literature. And we decided to go, after reviewing, decided to go with the size 32 millimeter valve directly without pre-dilatations. And also we planned for the 90-10 positioning, high position. And also, if we achieve the 95 is good. Also 0 is good, 0-100 ratio. And we achieved almostly, I think is 95-5 or 100-0 is good for the bicuspid and heavily calcified. Also, as we see, the result is good. There is no B-fail, and the valve is sealing well, expanded well at the nominal pressure or volume. And the echo later on, it's the gradient is 7, no paravalvular leak, the bifurcation is well seated, the mitral is very mild. And the, in conclusion from this one, the technology always help us in managing our patients in spite of the challenges we face. We should utilize the recommendations from the literature. There are equations how to calculate the oversizing unit, and also applying the available assessment measures like the circle method and the bicuspid aortic valve. Also, the recommendation is to go for bicuspid aortic valve. Heavily calcified, recommendation is always balloon, pre-dilatation balloon. But sometimes it carries some risk, it's not free of risk. And also to take the opportunity from the technology. And thank you.
Excellent, thank you. And we move on into the treatment of pure aortic regurgitation. I mean, it really describes the whole spectrum of possibilities with this particular valve. Ignacio.
So thank you very much. I will try, we are way behind the schedule, so I will try to go to the key slides for the audience. We have been trying to treat pure regurgitation transcatheter. We even have some dedicated devices like the GINA valve, but we still have second valve implantation, so embolization or failure, in a high proportion of patients with all the devices. This is the most recent meta-analysis that demonstrated these numbers of mortality or residual regurgitation, which are high. And even if we have some dedicated devices, like the GINA valve, they do not cover large annuli, which are the main kind of patients that currently we need to treat percutaneously because they are the sicker patients. For this reason, we did this study that my colleague has commented that was recently published in Neurointervention, the Pure AR. In this study, we included a total of 113 patients with moderate risk according to the scores, but actual very high risk, which is the reason why they were rejected for surgery. A few proportion of bicuspid patients, but a high proportion of aortic root dilatation. Most of them already had ventricular dysfunction, dilated ventricles, and in all of them it was only regurgitation, no stenosis. In fact, 85% of the patients did not have any calcification at all. The mean area was 638 and the mean perimeter 88, so very, very large. And 75% of them were treated with the 32 valve and 11% with the 30.5. So most of them with the extra large sizes. These are all our patients, and the degree of oversizing, mean oversizing was around 20%, but you can see these red dots are the patients. There were 4 embolizations, which is 3.8%, and the red dots are the ones that embolize, and you can see that all of them were below 10% of oversizing, so very, very large annuli, so we already can have a hint. There was also one here, but this was a mistakenly sizing for this patient. Also, you can see that the 32 valve at nominal volume covered an annuli of an area of 840, but you can see that 7 patients were out of that range. So even oversizing and increasing the volume, we were at the very limit of this size. And as I mentioned, there were 4 case embolizations, but the mortality at 30 days was 6.7%, and the residual regurgitation was moderate and severe in a very low proportion of patients patients. If we compare with the meta-analysis that I just commented, this was much better mortality and better rates of residual regurgitation than we have ever presented before with non-dedicated devices. And we have some long-term follow-up data at 12 months and even for some patients and longer-term follow-up with good rates of mortality and good rates of rehospitalization. This is one example. This was with a 29 valve with a nice result. This is what we have been treating until now, but this is a more challenging example, a patient with a non-calcified valve. You will see now the leaflets. Here you are, no calcium at all, and very dilated aorta. We'll advance the case. We use 2 pigtails to make sure we are in the right implanting position for our patients. One important thing is that usually we fear the aortic embolization and we tend to position the valve very high. That's a mistake because the valve tends to dive in the ventricle, not to go up. So it's important to go high enough. And this was the final result after the implant. This was a patient with a 32 valve plus 10 extra cc of volume. The leaflets were working properly. This patient already completed 1 year follow-up, no thrombosis, no dysfunction of the leaflets. So we have checked up to 10 extra cc in our patients. There were no cases of annular rupture, and this TE can show you that we are actually compressing the surrounding structures, but due to the lack of calcification, this is quite safe if we are within that range of overexpansion that I mentioned, around 20%. And all the patients that experienced embolization presented this shape of the LVOT, this taper shape. So if we are with this shape and we cannot reach 20% oversizing, it's better to avoid the implant in these patients because these are the highest risk ones. And what to do if we have an embolization? This was a case with a poor sizing, also a poor positioning. We were too deep, and the valve embolized to the ventricle once implanted. What can we do? These valves are not calcified, so very often we are able to remove this valve from the ventricle so that we can implant in the descending aorta and advance a second valve larger to achieve a greater oversizing, which was a mistake in this case, and finally achieve a good result. And this is the final aortography. So this can happen. We have to be ready to treat that and always have a backup valve. And now I want to go a little bit crazy and talk about endocarditis, because many of the patients that have endocarditis have aortic regurgitation due to this problem. We know it's a rare disease, but with very high in-hospital mortality, and we know that antibiotics work very well. Most of these patients heal correctly from the infection, but 50% of them require surgery because they have a residual lesion in the valve. They have often high surgical risk, and the guidelines do not contemplate the percutaneous treatment of these patients. We have cultured the tissue that we explant for aortic endocarditis, and when we have more than 10 days of antibiotics and it's not staph aureus, most of these cultures are negative, only 1 out of 29. So these valves are aseptic. So 2 years ago, we published this paper in JACC Intervention with 54 patients of endocarditis, like this case, with a perforation in one leaflet that we were able to treat with a transcatheter valve that is no longer in the market, as you can see. We could identify in these 54 patients a very high surgical risk. Some of them were prosthetic valves, some of them were native valves. All of them had very high surgical risk, and most of them, the residual lesion was regurgitation. The most common bacteria was Enterococci, but in prosthetic valves, it was more common the Staphylococcus aureus. We can see that the procedure was successful in around 85% of the patients, so not so high as in aortic stenosis, but a respectable number. And in hospital mortality was 5.6 with 3.7% stroke. At 1 year follow-up, these patients were doing well. The survival was adequate after treating them. Only one case of reinfection out of 54. And now this is not published yet, but we are exploring patients within the first 3 months after endocarditis, some of them still on antibiotics that need surgery but cannot undergo surgery. We have been gathering 41 aortic cases, 2 mitral and 1 tricuspid. This is one case, it's very long, so I will advance. It was a very dilated annulus. We have to use 32 plus 10 cc. We have a very high implant of the valve, and you can see that the result was there was a mild leak, a residual leak, but this patient could survive the infection. There was no reinfection of the valve. This was 6 months ago. And what we know is that in-hospital mortality in these early endocarditis cases is now 9%, but this can be a bridge therapy for surgery if we cannot offer other alternatives to these patients for survival. So thank you very much.
Fascinating, and I have about 1 million questions, but we should move on and wrap this up with Myval THV case, Kaleidoscope, George Ganem. Be very curious what's behind that title.
I like this word, kaleidoscope. It's colorful and light, and so will be my presentation, very light, and I will drive you through some few clinical cases. This is how Merrill advertised for the Myval, with all these characteristics, low profile, expandability, retrievability, high flexibility, user-friendly, size optimization, accurate deployment, precision in placement, certainly with the valve system, the delivery system, and the introducer sheet. I will try to highlight all this in our clinical practice. Just to start with this half sizes or intermediate sizes, it's very useful, and it seems that in our clinical practice and our series, we use these intermediate sizes in 45% of the population. The python cheese, also like a python snake, which allow to swallow the prey and the valve. It's very useful and stretchable and expandable, and this is one of its advantage. You can see here the minimal sizes for different valve size, at least 5.5 millimeter. I highlight this for the next clinical case I will show you. This is a 50-year-old female. I don't want to dwell more into the age. It's a specific psychiatric profile. We spent 6 months convincing her to go to surgery with no success. Multiple pulmonary edema, severe aortic stenosis, moderate mitral stenosis, first-degree AV block, intermediate risk score. The first thing I want to highlight the form of this annulus, and for the first time in our series we have a very completely different sizing. Usually we do the sizing with 2 different operators, and these sizes came out completely far from each other, 395 and 465. And this chunk of calcium at this level. But the other also characteristic in this lady, the very low left main, 6.8 millimeter. And the third problem is the femoral axis. We have here on the left 3.2 and on the right 4.5 at maximum with calcified iliac arteries. We decided to do it by femoral access, right radial access for pigtail, left femoral artery for left main protection, temporary pacemaker lead, and 1 proglide for closure. You can see here the left main very low. We did a pre-dilatation with a balloon, and also to resize a little bit and have an accurate measurement. We end up by taking a 23 millimeter device, the left main protection. Pre-dilatation was an 18 French sheath due to the rigidity and the calcification of this iliac artery, and you can see here the liseré of calcification on the iliac. and impossible to make this python swallowing this 23 millimeter device, despite all the intensity and the power we put to advance it. We were stuck with the guide wire into the left ventricle, and everything is in place. Either we have to retrieve everything and go for a shock wave, or at the end, I decided to put a 7 millimeter balloon inside the python sheath, keeping everything in place. And inflating this balloon, you can notice here some notch on the python. And after then, it was possible to advance with some difficulty, the advance to the valve into the landing zone and implanting it at this level and keeping the coronary completely well perfused with minimal paravalvular leak, and the control for the iliac was also very good. Another case also highlighting the coronary access, 86-year-old female patient, very severe aortic stenosis and low ejection fraction, very high STS score, with multiple comorbidities and very difficult manipulation into all the vascular access. And you can assess here the calcification burden on the valve, but not on the valve simple, but also on the ascending aorta. And these are were a chunk of calcification inside the lumen, not only on the wall of the aorta. And crossing with a balloon was difficult at this level. This is the balloon inflation and a very severe notch on the balloon. Implantation of the valve. Immediately after the implantation, almost a cardiac arrest, very slow flow on the coronaries, and as we discussed yesterday, the first reflex is to do an angiography and then to try to cross and to canalize the artery and to put to wire the left main LAD, the left main circumflex, with some pressure, and everything went normal after that. Then I will see this occasion to talk about a little bit of the coronary cannulation after TAVR, and this is the advantage of balloon-expandable valve, where we can still cannulate the artery in 95% compared to these figures from the self-expandable valve. According to the Align Access study, around 70% if we have a commissural alignment, but really a low percentage if we don't have for self-expandable valve a commissural alignment. Other feature we have to take into consideration which impair the cannulation, the size, the ratio between the valve and the valsalva, and the height of the valsalva. I will not go into the details for this slide, but we should keep this in mind, the room between our devices in preparing our TAVI, between the devices and arterial, the wall of the aorta, to still have a room in order to cannulate, or if we don't have, we have to try to spare for this condition. Certainly, Merrill will have, I think, in the near future, also, even though the alignment of these valves as for balloon expandable valve are good, in order of 50% of our spontaneous use, but maybe we'll have in the near future also another device, the Octa-Align technique, in order to have this kind of a clock helping the crimping of the device exactly at the middle of the right coronary cusp, which allow us in navigating through the aortic arch to have this post aligned to the posterior commissure between non-coronary and left coronary cusp, to help us to have a strict alignment of the commissure. What about the large annulus? The previous speaker talked a lot about this. In these cases, here, for example, a large annulus, 750, 780 millimeter, It was a challenged anatomy, low ejection fraction, and a huge calcium burden, as you see here on this image. In these cases, I prefer always to pre-dilate and to downsize a little bit my valve. Theoretically, a 32 millimeter valve is needed here, but we downsize it to 29 with some more cc's. Actually, we don't have any idea about these supplementary cc's in terms of centimeters of millimeter gained. And you can see here that we have this small calcification, still mobile between the frame of the valve and the aorta, but I prefer to have this not to compress completely and have a major problem at this level. I think that sometimes we have to respect a little bit and give a room to this calcification to stay in place and not to cross the aortic annulus. In bicuspid aortic valve, certainly yesterday also we discussed this extensively, and for the measurement, which is a crucial step in sizing our valve. Certainly we have to measure the annulus, we have to measure the raphe, the calcified raphe, we have to measure, have multiple measurements and take an average. Here for this 760 millimeter, also I downsize the valve and put some more cc's in order also to respect the calcification and in this very calcified type 1 bicuspid valve. Porcelain aorta, we have multiple cases with this, only to show you the navigability of this valve through all this hard, difficult anatomy with calcified aorta from the iliacs, abdominal aorta to the ascending aorta, and really the user-friendly of this valve, and it's help us a lot to navigate into this, as well as in this severe kyphoscoliosis, where we have no problem in navigating into all this curve of the aorta and delivering the valve. In our center, we do almost all our TAVI in femoral approach. We had a previous experience with trans-aortic, very small experience with trans-aortic, but now we try to make it by transfemoral, as you see, even for a small diameter. Here, for example, we prepare it by a shock wave before entering with the device and having multiple problem. And it was after then easy to handle all this anatomy and calcification and navigate into the landing zone and release the valve. The problem with the Myval probably is the pushability of the device, which is maybe the one of the very few, if maybe the only one disadvantage of the valve, the pushability of it, but we can always have a lot of other benefit from the other characteristic of the valve to handle this. Last case of also mitral transmitral valve implantation, and this lady was failed bioprosthesis, high gradient, high pulmonary pressure. The preparation and the scan shows a suitable angle between the aorta and the mitral valve, around 120 degree. Here the puncture, a little bit preparation of the puncture site and the procedure. We cross it as we cross it usually for balloon mitral valvuloplasty with the in-way guide wire and the dilator, the Agilis catheter, the pigtail crossing to the left ventricle, the safari wire, We continue our septum enlargement with 8 millimeter balloon. And we advanced the valve. We took this second dark zone at the level of the frame of the bioprosthesis, and we delivered this valve with a beautiful result. These were our kaleidoscope for this valve and is ready to finish this beautiful session. Thank you.
Thank you very much for that kaleidoscope at the end of this interesting session. We're well beyond our allocated time, so I just summarize. We have seen new technology in this session. In the coronary sector, a bifurcation stent that wasn't there before, new scaffold generation, and a tapered stent that looks interesting, and there is large-scale focal experience with these devices. The Myval, a whole valve system, not just the valve. In the meantime, tried and tested really in a wide variety of standard and also challenging procedures, as we have seen. And next year, we will add randomized data to the wealth of already existing experience. I thank my panel and the speakers, and we close this session. I think there is lunch out there. There's a break of 1 hour now. Thank you.
Thank you.